Hello everyone, welcome you all to Medical Concepto. So today we will be talking about idiopathic thrombocytopenic purpura. So let's begin with a clinical scenario first. So you are on your duty and a patient comes to you with the gum bleeding, epistaxis and purpuritic spot. So you ordered and full blood count and you got the report. On the report you can see there is very low platelet count. So what is your approach to the patient? How are you going to manage this case? So think about this a little bit. We'll come back to this at the end of our session. Now let's talk about idiopathic thrombocytopenic purpura. What do you mean by this? The word the idiopathic thrombocytopenic purpura. So the thrombocytopenia means here there is low platelet count, and purpura means there is skin hemorrhage. So it's a simple thing that there is low platelet count on your body. As a result, there will be because of this low platelet count, there will be skin hemorrhage on your body. So let's talk about how this thing happen actually in your body. So first, it's an immune mediated disease with involvement of autoantibodies. That means that there is production of antibodies against your self antigen. In this case, the antibodies are produced against glycoprotein 2b3 receptor that are present on platelet membrane. Do you know what is the role of platelet on our body? Can you say that? Yes, the role of platelet is hemostasis in our body. And what is the normal count of platelet? Yes, that is 140 to 400 into 10 to the power 9 per liter. So that thing is the platelet is most important for our body for the hemostatic function or the formation of the platelet plug. In this case, if the platelet plug is not formed, then there will be then there will be bleeding from our body. So in this case of ITP, there will be destruction of this platelet by the formation of autoantibody against the glycoprotein 2b3 receptor, and the distracted and the deformed platelet are removed from your circulation by the reticuloendothelial cells. As you can see here that if there is any kind of vessel injury in your body, then there will be formation of hemostatic plug. But for the formation of this hemostatic plug, there must be activation of glycoprotein 2b3 receptor. Now let's talk about this thing that we have talked earlier, that the function of platelet is hemostasis and normal count is 140 to 400 into 10 to the power 9 per liter. Here you can see that the glycoprotein 2b3 receptor play a very important role in the formation of the platelet aggregation. If there is no glycoprotein 2b3 receptor, there will be no aggregation of the platelet. As a result, there will be no hemostatic plaque formation. So in case a patient of ITP, there may be a history of vaccination or an infection such as chickenpox or infectious mononucleosis. So a simple thing is that here is ITP can be two types, acute or chronic. In case of acute ITP, it occurs most commonly in children. So in case of children, there may be a history of vaccination or an infection such as chickenpox or infection in infectious mononucleosis. So let's go to our clinical manifestation. Can you say one or two things that occur in a patient of ITP? What are the clinical features that the patient will present to you as a history, as their clinical manifestation? So simple tip is that there will be a low platelet count. So what are the conditions that can occur as a cause of the low platelet count? So the first thing is that the patient can have a clinical manifestation of spontaneous bleeding. This thing happens when the platelet count is below the 20 into 10 to the power 9 per liter. So another thing that happens is easy bruising or sometimes epistaxis or menorrhagia. There may be also a clinical manifestation of purpura. So these are the things you need to remember, that patient may be present with spontaneous bleeding when the platelet count is far below the normal. There may be a easy bruising, sometimes epistaxis or menorrhagia, and there may be also purpura. So let's talk about a little bit about purpura. So here you can see a picture of purpura. These are the skin hemorrhages. Diameter is around 3 to 10 millimeter. So the thing is most important about purpura is that the purpura in case of thrombocytopenia is non-palpable and non-tender. So this thing you must have to remember, that in case of thrombocytopenia there will be non-palpable and non-tender purpura. So in case of vasculitis there will also be purpura, but in that case that will be palpable and painful. So in case of patient of an ITP, there may be also of association of other disease. These diseases are like connective tissue disease, HIV infection, and B-cell malignancies, and there may be also case of certain drug therapies. So the thing is that in case of a patient of ITP, we should also investigate for the association of these diseases also. So let's move on to the investigation. So in a patient, so the patient comes to you with the history of bleeding and purpura, and also history of menorrhagia, female patient. So how will you investigate this case? So the first thing you have to do is to order an CBC or full blood count with PBF, and you can also do the bone marrow examination. So the primary thing you have to do is CBC with PBF. So in case of CBC, you will get an thrombocytopenia, that means low platelet count. As we have discussed earlier, that the platelet membrane is being removed, as the platelet is removed from your circulation by the macrophages or reticuloendothelial cells, there will be low platelet count, and that means thrombocytopenia. As bone marrow is trying to compensate this increased amount of loss of platelets, so there will be increase in megakaryocytes. So for the association of other disease like connective tissue disease or HIV infection, you can also go for HIV screening and autoantibody for connective tissue disease. So let's move on to the management. How will you manage a case of idiopathic thrombocytopenic purpura? So if a patient comes to you with a platelet count more than 13 to 10 to the power 9 per liter, in that case you don't need any kind of treatment to raise the platelet count. So that's a simple thing. Patient comes to you, you ordered an CBC, and here is the platelet count is more than 13 to 10 to the power 9 per liter. So you don't need to give any kind of treatment to raise the platelet count. But there is some exception. The exception is that if the patient is undergoing a surgery of the patient, if you need to take a biopsy from the patient, in that case you need to interfere with this kind of situation. So a patient present to you with spontaneous bleeding, what will you do? In that case, you have to go for a first line therapy. What are the first line therapy? That is glucocorticoids and IV immunoglobulin. So a patient present to you with platelet count less than 20 into 10 to the power 9 per liter. In that case, you have to go for first line therapy. And what are the first line therapies? Glucocorticoids and IV immunoglobulin, high doses of IV immunoglobulin. So what is the role of glucocorticoid and IV immunoglobulin in the body in case of idiopathic thrombocytopenic purpura? So in case of glucocorticoid, it suppresses antibody production and inhibit phagocytosis by the sensitized platelets by reticuloendothelial cell. In case of immunoglobulin, it raises the platelet count by blocking antibody receptor reticuloendothelial cell. So the thing is that glucocorticoid will suppress the antibody production and inhibit the phagocytosis process. And in case of immunoglobulin, they will block the antibody receptor on the reticuloendothelial cell. As a result, there will be raised platelet count. So if a patient present to you with persistent or potentially life-threatening bleeding, in that case you have to go for platelet transfusion. Again, if a patient comes to you with a relapse, in that case you have to treat the patient with glucocorticoid. So in case of simple thing to remember, that if a patient present to you with persistent or life-threatening bleeding, in that case you have to do the platelet transfusion. If patient present to you with one relapse, in that case you have to treat the patient with glucocorticoid. So if the patient presents to you with two relapses or primary refractory disease, in that case you have to go for second line therapies. So what are the second line therapies? That is thrombopoietin receptor agonist and splenectomy. You can also go for immunosuppression. So simple thing to remember, that firstly, if a patient present to you with platelet count more than 13 to 10 to the power 9 per liter, in that case you don't need to recur any intervention. If the patient presents to you with spontaneous bleeding, then you have to give the patient IV immunoglobulin and glucocorticoid. And if the patient comes to you with one relapse, you have to treat the patient with glucocorticoid. If the patient comes to you with potentially life-threatening bleeding, in that case you have to treat the patient with platelet transfusion. If the patient comes to you with two relapses or primary refractory disease, then in that case you have to go for second line therapies. What are the second line therapies? That is thrombopoietin receptor agonist, and you can also go for splenectomy, but is not widely used. So what are the immunosuppressive drug you can use for ITP? The drugs are rituximab and cyclosporine. These are the things you have to remember, that if a patient comes to you with two relapses, then you have to go for second line therapies. The second line therapies are thrombopoietin receptor agonist, and you can also go for immunosuppressive drugs and splenectomy. So Let's come to the case that we have discussed earlier in our slide. So what will be your management? What is your diagnosis in this case? So the diagnosis is idiopathic thrombocytopenic purpura. So how are you going to manage this case? So as the patient has a platelet count far below the normal, that is 20 into 10 to the power 9 per liter, so the patient develops spontaneous bleeding. In that case, we have to treat the patient with uh, high doses of IV immunoglobulin and glucocorticoid. So at this time patient will be asymptomatic, but if the patient again presents to you with the same problem, what will you do? In that case, you have to treat the patient again with glucocorticoid. If the patient comes to you second time with the same problem, what are you going to do in that case? Yes, in that case, you have to go for the second line therapies. What are the second line therapies in that case? Thrombopoietin receptor agonist. You have to also go for immunosuppressive drug. Also, another option available for you, that is splenectomy. You can also go for splenectomy. So, with this, I would like to end our session today. Thank you all for patient hearing, and stay with us and stay safe. Thank you.